Hi, it's me, Termo, Motivation and Beard. Welcome to this new video. I'm glad to have you back today for the second part of the interview we did with Cristina. I'm glad, as I said last time, for the opportunity to have done this interview. And soon we will have also another interview with a physiotherapist who followed me both before the amputation and after. For now, let's focus on the interview with Cristina though. I wanted to take a small moment to thank you for the follows, the likes, the shares, the comments, here, but especially in other social networks. They are very much appreciated. I really appreciate your constructive comments, because they help me to improve. As an example, I was suggested the microphone for the audio. I'm trying to improve, so I hope that this time you will hear a little bit better, because I tried to make some changes. They are still not final, but I'm trying to structure myself. So I ask you for a little more patience, and because I'm trying to invest the right resources to improve the quality of these videos. Thanks are done. I think we can start with the second part of the interview. So enjoy today's video.
There is a right gradient of moisture, because I say it all openly here and I emphasize it and I underline it. Wounds heal in a moist environment. They shouldn't be allowed to dry out or they'll never heal. There's a proper moisture gradient that the wound needs to be in, and the negative pressure does that. Plus, it assists because it results in the formation of a new vessel, so oxygen and blood. It has a continuous cleaning. The dressing, if it is in foam, is changed every 48 hours. If in a gauze, every 72 hours. And of course it depends. For how long? Depends on the injury. However, there are guidelines, including regional ones, that tell you that after 21, maximum 28 days, it is not the case to use it, because it must take effect in a short time and does not serve to heal wounds. It serves to improve the bed of the lesion and then proceed to a plastic surgery, then a graft, a flap rotation or whatever, also called advanced dressings.
Okay, so yes, like the plastic surgery that I did, or at least that too. In fact, the next question is, what are the various methods to heal such a wound? Are there any new ones compared to those used on me at the time?
Negative pressure therapy is used to improve the local perfusion of the lesion and to improve the appearance of the lesion to prevent it from becoming infected. Or even better, there are also lesions like infected lesions that are very suggestive, and so it's used for that as well. Because, in fact, doing a general antibiotic therapy, having this type of lesion and washing it continuously, we got to break down the infection, everything that there is to improve the bed of the lesion. Once, we always say, the tissue has come up, so the cavity is filled, we decide whether to continue with advanced dressing or plastic surgery. What are the methods? We make a sort of meeting and decide on the basis of who the patient is, what the patient has. If there are contaminant disease, they may compromise, for example, the routing of a graft or a flap. The rotation flap essentially takes a small piece of muscle or flap, but more often muscle, and rotates directly on the bed of the lesion and remains attached, so the patient is told, yes, we close the main wound, however, you will also have the wound from where we take this flap to close, so it's two wounds. The other one is the graft which can be the autologous dermoepidermal outcome, meaning the patient's skin is taken by hand at the superficial level and it's attached like a net to the bed of the lesion. Then recently the new derma have come out. These are special things that are placed on the bed of the lesion. They help make the skin close faster, and they are the so-called dermal substitutes. It depends on the type of the lesion, the etiology of the lesion, if there are underlying pathology, and the age of the patient. Among the dermal substitutes that were also there at the time, which were more like just collagen, lately, from the experience of the Indians in the Amazon, this experience has been brought to Europe. What do the Indians do when they have a burn or a very bad wound? They fish for tilapia, which is a fish they have there. They eat it and then use skin instead of throwing it away. They put it on the burnt. Brazilian doctors saw this, and seeing that they heal without pain and without anything, they took up this experience, and from Brazil it was then exported all over the world. In Europe there is the fish skin of the Atlantic cod, and, as with pork, you don't throw anything away. It's the same with cod. So, the actual cod is left to Captain Findus for the food industry, and the fish skin is obviously treated in such a way that it doesn't smell, which is the only problem. But because there's no chance of cross-infection with humans, it's not treated with antibiotics as other dermal substitutes are treated, most of them bovine. All the proteins remain on the same as those of the skin, so in reality it's not a true dermal substitute, but it is a skin for skin. Because even the electron microscope, evidently we derive from fish, our skin is the same as fish skin. And it seems that in addition to acting as a so-called scaffold, that is, to act as a brick to put the skin graft on, it can also close wounds.
Wow, that's very, very interesting. How many people have you had the opportunity to follow who have undergone an amputation, whether it was traumatic or therapeutic?
Not very many, because again, the key thing at the time, since I'm not in the group now, but I remember when I was in the hospital, the key thing was to save the limb as much as possible. It was just, we had to do it because, I repeat, we are Italians and we put a lot of heart into it, probably. But yes, there were traumatic amputations. Therapeutic amputation, never any, because at the moment, as you well know, here you had a lot of problems to have your leg amputated. Because for the orthopedics it's almost a failure to do such a thing, so it is not easy to find an orthopedist who can decide to do it. Traumatic amputation, both directly already during the trauma or in the operating room, because actually the limb was completely mangled. Yes, there were. There, obviously, you do it at the very end. Sadly happens, and you only have left to try to support the patient. What is definitely missing, especially in orthopedics, because if I'm not mistaken, in pediatric oncology or oncopathology there is anyway the figure of the psychologist. Unfortunately, it is not foreseen also in traumatology. In my opinion, it would be necessary because, especially when it comes to traumatic amputations, now also a bit from therapeutic amputations. Anyway, there should be a psychological support, but not only for the patient, also for doctors and nurses. Because we nurses are especially in contact with the patient and sometimes we lack words. The right words. Maybe we say things a little too obvious, no, or things that, I don't know, why did I tell him this crap? I could save it. Because we don't have the expertise. From this point of view, we don't have the necessary skills, so having even a psychologist within the team, in this case, in my opinion, would make a difference.
This is actually a very interesting thing, and a good suggestion to give to all our listeners in the field. Also because although I have a little memory of those times, I remember that sometimes I was told too many words. And by too many, I simply mean a few more hopes given, because this does a lot on a psychological level in a situation like this.
Exactly, this thing we nurses miss a little bit. Let's not even mention doctors, except in very rare cases, as you have seen with orthopedists. Unless they treat bone tumors, which is a different environment, the orthopedists who deal with traumatology are very good. They are exceptional people, but sometimes they lack a bit of tact. However, they realize that they feel in difficulty, so they often send a nurse ahead. So yes, it would be necessary to provide training courses, not only psychological support, but also training courses from staff who are faced with these situations.
We are coming towards the end. And so my next question for you is, on a professional level, how it is to treat an amputation compared to a wound that, yes, may be serious, but is not of the same entity.
Maybe it's because I've lived your whole journey not as a nurse but now as a friend, because then, in the end, it always works out that way. The nurse vulnologist, you don't know for what reason, but then, in the end, is part of the patient's family. Well, knowing all about your journey, what you have been through, I definitely have. I was a little bit left there, I have to say at first. Now I actually put myself in your shoes and I realized that the choice you made was a very brave one, but I would have done it too in your conditions. I said, if I remember correctly, that I would have done it too, that you were right to have proceeded with these therapeutic operations, because actually you have to put on the scale the well-being and the moving forward, your position and the wounds, always coming to the hospital, always there, always thinking of being sick and never getting out. This is detrimental from all points of view, even physically, so no. From my point of view, at that point, I said, come on, I have to close him. I have to help him close because then he starts a new path, a path of growth, of a different life, of a new life and a new adventures. So let's move on. I then am very optimistic. I always see the positive side of the situation and I try to give it to my patient as well. I never say looking at the wound, no, that sucks, or maybe making strange faces. I always avoid it because I try to always give hope. Obviously, if there are worms in it, no, I'm not faking it. In that case, no. But I always try to make the patient feel calm because I have always thought that if you deal with things by crying, they all go wrong. If you face them with sure fear, because it's always the fear of what can happen, the unknown, oh God, what's going to happen to me? That's a positive, active, proactive fear. And then also an extra smile that never hurts.
Alright, very last question now. If you were to have a patient, ask for your advice regarding an important choice, such as deciding to amputate a diseased limb. What would you advise them to consider in their choice? Because I, who am not a doctor nor a nurse, suggest to take into consideration the quality of life. Would you add something from a purely professional point of view?
No, I don't, because what kind of advice can I give from a professional point of view? I mean, my advice from my professional point of view is this: listen to yourself. Because the first doctor of ourselves is ourselves. So you have to listen, you have to evaluate what you're doing and how you're living your life. If it's satisfying, if it's not satisfying, because, for example, I often get young patients with injuries that happen so out of the blue. You don't know why, there is no rational reason, right? There is no reason why this skin lesion comes up. Let me bring you an example. A girl with a very ugly lesion after waxing at the beautician, a lesion that took her into intensive care, saved by the skin of her teeth. A really bad infection happened on this injury from a bikini wax, a really stupid thing. Then, instead, you go and talk to this person and you realize that she was going through a very bad time in her family, that she had had a series of bereavements and was in a bad condition. Anyway, she was not living well. She had lost her job. In short, a whole series of stresses caused her immune system to drop. And all it took was a very small thing to get her into intensive care, a very strange thing. So I always say to all patients or to those who tell me, look, I want to amputate a leg because I can't take it anymore, because I always have to go and do, always sick, because I'm always in the hospital. I don't want to live my life and spend 7 times out of 10 of my time in the hospital. So there you have it. If that's not what you want, make a way to eliminate the cause of all these things, and most importantly, deal with them in such a way that all this stress that you are experiencing right now doesn't go and mess with your immune system, because then all it takes is nothing and you come up with anything and everything. I talk to you about skin lesions because that's my professional experience, but gastritis, heart problems, intestinal problems, even autoimmune disease come out like this because people, especially women, who are very good at swallowing and pretending nothing happened. Then eventually the body somehow alerts you that there's ongoing stress and you need to remedy it. And the only way to get you to sit still and start thinking about yourself is to get something to come up. That's how it is, that's how it works. We are body and soul, brain 1 and brain 2, call it what you will, but we are one. So if there is something not right in your life, try to remedy it. I help you with my professionalism, I help you with medication, I give you some indication and tell you that if this comes out, you could have this thing, move your leg this way, sleep this way, take these supplements instead of something else, do this type of massage, call the physiotherapist, or give you a series of suggestions. But the decision is always up to the patient, always up to the individual. I support you, but you have to make sure that you deal with the issue. If you don't deal with them, sooner or later they will come out in some other way.
Thank you very much, Cristina, because this is very important to me. As you know, I'm trying to share these videos with as many people as possible around the world, trying to motivate people to live peacefully and reconnect with their inner selves. Because as you explained it very well, there is a very important connection within us, and it is important to take into account also that of the professionals who work with people who have problems similar to mine, and not only. So, thank you very much for this intervention.
You're welcome. Bye.
That's it for today. We have reached the end of this video. I am, as I said at the beginning of this video, and the previous one as well, extremely happy for the opportunity that I had to make this experience. To shoot this interview with Cristina, for her willingness to share not only some notions of a professional level with us, but also, well, all that path has been for her emotional. For me, she has been and remains an important person and a great friend. I'm really happy to have had her approval in this and her availability to shoot this interview. I'm especially glad because I hope that her words can reach not only the people who are being treated and therefore have more knowledge about their condition, or however, people who are not necessarily amputees or have injuries, because the final part especially, as you could hear, mainly concerns the care of the self-person, regardless of a traumatic injury. Because as that girl's example Cristina made, it only takes a little bit. Really, if we have some kind of confusion in our insides, if we don't handle stress well, if we don't handle situations around us well, if we don't pay attention to our moods and let our bodies vent everything we have inside, it can take us to extreme conditions. Again, an infinite thank you to you, Cristina. Or rather, mwah! As she finished the interview, I want to finish this video by sending her a big kiss, thanking her again infinitely for her intervention. If you are not subscribed to my channel yet, I invite you to do so now by clicking the subscribe button, then on the bell to activate the notifications so you will not miss any of my content again. The due thanks have been given. All that remains is to wish you a good evening. See you in the next video.